uh, oh yeah, and warning, I believe the nationwide emergency alert system is going to go off in another 15 minutes for everybody in the US. So please note that. So my project has been in Rwanda, looking at creating an electronic communication platform for the EMS system, so the dispatch staff, so that they can be coordinated. The first and most important part of it has been geolocation, using GPS to determine where a patient might be, where a caller may be. And then the second huge part of it, of the project, which is really in two phases, is looking at how do we, once you identify the patient, how can you gather the right information from hospitals to know which hospital has resources patient, so that then the EMS ambulance can appropriately take the patient to that location. These are two phases of a project that is funded by the U.S. and UK government through various universities. The biggest challenge that we've been currently struggling with, so we're now in year 3 of essentially 6 years of 2 different funding streams, and we were supposed to implement this software. Created software, tested it, trained everybody, and we were in the process of getting ready to launch it, convert the pen and paper radio-based system in Apple City to just the electronic. And then, of course, there was a big curveball that we got 2 weeks ago from the government, which is that they are so enamored now with EMS and recognize it for it that they decided to triple the workforce and buy an additional 750. And of course, all of this made, just happens tomorrow. And so immediately the next day, there were 100 people who reported to duty to be assigned, trained, etc. So it's completely thrown a big wrench into our plans to train everybody on the software platform and implement it, because we now, instead of training 50 people, which we had done in 6 months, we now have another 100 people to train. And so that's the biggest challenge we're fighting for. The attendant complication, there's just training all the people and figure out how to do that, but getting additional mobile devices. The ambulances were initially set up at 2 different base camps. There are now 16 different base camps. So now we have to think about what's the infrastructure at the base camps, how many phones do we need for mobile devices, how to budget that, etc. So there's been a lot of complexity that has been into the project for the last couple of weeks. And then meanwhile, we're working on just collecting and organizing data so that we can do what's called an interrupted series analysis before and after.
Hey, Sudha, we're having a real hard time hearing you, going in and out. Sounds like there's other voices. We're really having a hard take our chairman with us for the first week. Our project included really 3 different aspects. One was starting the beginning of advanced laparoscopic training at CalMet Hospital, the main public hospital. 2 was to start a basic skills training at a site that we hope to take laparoscopy to next year at Kampong Thom. And then a third option, part of it was the last week going to Kampong Cham to do follow-up from where we introduced laparoscopy in February, and do 1 week of continued training there as well. And before I go further, Liz, can you hear me all right? Is my voice coming through okay?
Yeah, your audio is perfect right now.
Okay, thanks. The advanced laparoscopy team actually was 2 weeks in the Capitol. They came up on the weekend to help do the skills training, most of them, and then they went back to the Capitol, and then the other half of the team went up to Kampong Cham. We had in the Capitol, we had 2 days of didactics on foregut, colorectal, and adrenal surgery. We had a day of skills training in the skills lab that we set up previously. And then we had 2 days of operating of some laparoscopic colectomies. Dr. Nariaku was able to do a laparoscopic adrenalectomy with the team there, and they were blown away with the exposure and pretty excited. The urologists have done 12, but they said they've never seen one like that before, and we're just really thrilled. We taught 4 surgeons the skills training up in Kampong Cham. We installed a laparoscopic training box there. Our team set up a QR code where they're supposed to be inputting all their skills times and their scores over the next several months as we prepare to go there as part of the training for setting up laparoscopy at this new site. We did have anesthesia with us and did a really big site visit for anesthesia at this site, and have some concerns about anesthesia there that we're going to have to work out. And in the Capitol, where some people went back, they did some advanced laparoscopic cases of colectomies and colostomy closures, but also were able to do some open common bile duct reconstructions. And then in Kampong Cham, we did 15 laparoscopic cholecystectomies with the team there, and we were actually blown away with the dramatic improvement in their skills. The data being collected shows that they have more than doubled the number of gallbladders already by September of this year that they did all of last year. This is a total of open and laparoscopic, with most of the ones this year being laparoscopic. There were 2 partial bile duct injuries treated with T-tubes. One of the T-tubes is out, patient doing well. The other one is being studied here in another week. They had 1 post-op bleed about 8 days or 10 days post-op, where the cystic artery began to bleed for some reason afterwards. And then, so it was overall a good trip. We had Dr. Naraku meet with Dr. Dara. The changes at Calmet Hospital, the previous hospital director has been made the Minister of Health. Dr. Dara, who is the father of Dr. Vidya, who we work with a lot, is now the second in command at the Ministry of Health over quality for all the hospitals in Cambodia. And so Dr. Naraku was able to have good discussion about really kind of long-term engagement, not just for laparoscopy, but for quality initiatives, possibly even hospital kind of management potential with coordinating some things with the business school that Dr. Dara seemed pretty excited about as well. We had, like I say, colorectal surgeon with us, Dr. Huang. We had Dr. Nariaku. We had a biotechnician. We had Stacy from that came that was actually interviewing patients, filming, and getting a written permission to use that so we can tell the story, and all of our data collection there as well. So that's our update. Sudha, are you still there?
I'm trying to troubleshoot and see if I can log in again. So hang on. Why don't you all continue, and I'll be back in a second.
I maybe want to comment on this. We're working for our project in Cambodia. It's a partnership with the Association of the Church of Jesus Christ of Latter-day Saints. One big challenge we found is the equipment that was donated at both at the Capitol and up in Kampong Cham was of such poor quality, it's falling apart already. And so we've met with Storz and another company, come up with some other proposals. It's a much more expensive equipment we've submitted for the association. We're going to see if they're going to bite on it, but we have to have better equipment if we're going to continue to do this kind of work there. I think that's a really important thing, is how we donate equipment appropriately and how we find businesses to support them if we're going to be doing that, and use quality tools. And this was a problem with the way it was done this year. So so who else is on? Let's take a look who's on the line here. Let's see if we can.
I'm back on. I don't know if anybody can hear me.
Yep, I can hear you there.
Less background noise, maybe.
Did you welcome Laurie Bauman today?
I did. I did. I didn't introduce her, but Lori, maybe you can introduce yourself to the group.
Sure, I'd be happy to. Hi, everybody. My name is Laurie Bauman. I am the newest faculty in the Department of Pediatric Surgery. I just started on Monday, so I just got to Utah last week. But I have a background in public health as well as experiences within global surgery, and it's one of my passions. I've worked with Dr. Price actually a number of times, specifically within his work at SAGES and the international, it's kind of now the GLAP program. It was ILAP at the time, and we've been to Mexico together a few times. I've also spent time in Malawi within residency. My specific interests are in Latin America. I lived in Peru for a few years and speak Spanish. And so my goal is to pursue projects within probably education, training, as well as clinical improvements in Latin America. And but open also to joining on to other projects and partnerships. And so I'm just here I'm ready to get started and get to know you guys.
And welcome. We are so thrilled you're finally starting.
Yes. And hopefully I'll be the bridge to the Department of Pediatric Surgery, since I think that remains to be built. So let's hope that will be my role here.
Sounds fantastic. Thank you. Usually we just go around and talk about different projects. I think Mary, would you like to talk a little bit about your I don't know if you have a project yet for your master's program or any ideas, but maybe you can introduce yourself and give a little background on what you're doing and what ideas you've been thinking about. I don't know if Mary can hear me. Mary, are you there? Yeah, go ahead, Mary.
And so, we can't hear you, Sudha. It sounds good.
Thank you. But I don't know, we can't hear Mary now. Well, Mary is one of our, one of the several people in the Masters of Science and Clinical Investigation Global Health Innovation track. And she is a nurse midwife by training and leads a lot of work with PIGO, which is an NGO. Historically has done a lot of women's health work, but really has expanded to a lot of community medicine as well as surgery. Mary, can you try to say something? I don't know if we can hear you. Mary started in this program just about a month or two ago, and we'll be working on some projects related to
overhaul in KT, one of the provinces that we work in. We've had some struggles collecting the OR data to a depth that we want to collect in Kampong Cham, actually, sorry, not KT. And that data, we were able to, somebody met with one of the people there and was able to work with them on trying to fill out more information, such as length of stay, the type of anesthetic used, who the actual doctor was that did the surgery, just little things that previously they weren't inputting. They were just doing whether it was open or laparoscopic, which doesn't give us a lot of information. So that's been probably the most beneficial thing, I think, is now getting that much more in-depth log that we can follow up with the patients and kind of review that data. Those are the two biggest things I think from my end regarding Cambodia. Talked to Dr. Nunez a little bit. He's doing more work in Mongolia. They have some interviews and things that he's wanting me to try to translate for him. So some work coming in the ATLS field with Mongolia with Dr. Nunez. And that's probably my only real updates. The master's going great. I started that master's program as well with Mary, one of the students. Been very beneficial in learning a lot about public health systems and innovation and things that have worked around the world for different doctors and all metrics and fields from pediatrics to adult to, educational. So I think the biggest thing I've really taken away is needing to study more on implementation science and implementation research, and that there is a whole field that is all about how you make things work in these countries or work together and measure those. So it's been great.
Thanks, Leif. I think we have Mary back. Mary, I introduced you. I don't know if you want to say a little bit about any specific projects you're thinking about. I can't hear you, Mary. I can see you talking, but I can't hear you. I don't know if that's just me. Can anybody else hear her?
No, same thing.
Okay, all right. You may have to go down to your microphone button and change to a different microphone. Okay. You troubleshoot. We're all taking turns troubleshooting. Dr. Femi Odusola, I don't know if I'm saying your name correctly, but I know that you were one of Dr. Noriaku's colleagues, partners, and I wonder if you could talk a little bit about how your projects are going.
Yes, actually, good evening from Lagos, everybody. Thank you very much. I actually have in mind to prepare a presentation on my project, which is not at the moment. So I will perhaps just prefer to have a slot in the next few weeks where I can give an update or an overview of what we are doing in Lagos on one of Dr. Noriaku's projects in Lagos.
Dr. Femi, you can even just give a just general overview of what it is that you're working on now. This is more just to share the types of projects and challenges or things like that. So this is meant to be an informal meeting.
Oh.
Can you hear me?
Yeah, I can hear you. I can hear you.
Okay.
Well, basically, let me just give an insight into what we do at the particular aspect of the project I'm working on at the moment. So we're looking at how we can improve the quality of pre-hospital trauma care that's available to Lagos residents. From the point of view of the state organized ambulance service, which we call Lagos State Ambulance Service. That's a public ambulance service in Lagos State, Nigeria. It's the only public ambulance service in Lagos State in Nigeria. So we're working with Lagos State Ambulance Service, otherwise called LASAMBOS, Lagos State Ambulance Service, to try and improve the quality of pre-hospital trauma care, pre-hospital ambulance care that is available to residents of Lagos State. And we're looking at one or two key parameters regarding the response time between when an accident is reported and the ambulance team arrives at the accident site. We're looking at how we can improve the response time. That is how we can limit the response time or reduce the response time. So crash victims are able to access care as quickly as possible, and hopefully that will limit it will improve the survivability of the victims, and also it will also assist in getting the needed care quickly to them at the crash site, and effect an evacuation to hospital management where necessary. So, so basically, we're looking at our response, and we're also looking at the potential to implement the use of a mobile application that is targeted at quickening response. We have a mobile application that we have come up with at the moment, but we have not gone to the field we are in the process of organizing a pilot for that mobile application and see how it can assist in so many ways, not just in reducing response time, but also in sensing what we are, because one of the challenges we have in this part of the world is not just in terms of getting care quickly to crash victims, but also for those that might need require evacuation to hospital care. The challenge is that many of the hospitals, many of the facilities may not have bed space available to accommodate such victims. And so you find a situation where an ambulance evacuates a crash victim to a particular hospital, and the ambulance crew are told that there's no bed space. They have to relocate to another hospital. They may get to the other hospital and they may be told the same thing. So this lengthens the time available for the right care, in hospital care for these patients. And of course, it affects their survivability, increased morbidity, potentiates mortality for the patient. So the mobile application is also equipped in such a way that it can already assess which hospital that is most appropriate for that particular care, that has a bed space available before the ambulance crew get on to approach such a hospital, so that unnecessary wastage of time is not encountered in the process of evacuating patients to appropriate care in the long run. So looking at these, also to try to improve the overall quality of care available, we are planning along with the pilot study to pilot the mobile application. We're going to also talk to stakeholders in the field of pre-hospital trauma care. We're going to be talking to various stakeholders in stakeholder groups in Lagos, including the police traffic department, the Lagos State Ambulance Service emergency crew themselves. We're going to be talking to the Federal Road Service Commission. We're going to be talking to others like the Fire Brigade Service and the Lagos State Emergency Management Authority, and a couple of others. And we're also going to be talking to first responders too, identifiable first responders, and even crash victims themselves. We're going to access a database where we can have access to crash victims who have been managed and discharged from hospitals. So it's going to be a qualitative study, so to speak, to try and assess and get their views about how the quality of pre-hospital trauma care can be improved in the future, because the overview of responses, analyzed responses, and from these groups of stakeholders with regards to barriers and maybe facilitators that I experienced or encountered in the process of delivering pre-hospital trauma care, and also what are the views of the patients themselves, or crash victims themselves, or first responders themselves. So all this will be looked into in a qualitative interview study, and the outcomes will be very useful in providing actionable information for improvement in the pre-hospital trauma care that's available to Lagos State. So some of the other things that we have looked at in the past, and it's spatial and temporal. We have access to quite substantial data of past emergency response encounters carried out by the Lagos State Ambulance Service over the past years. So we've looked into what are the spatial and temporal dimensions of those responses that have been carried out in the past. And we are also trying to compare what happens in normal situations. Well, when I say normal situation, I'm talking about usual care, and in what I can call unusual care or unusual situation in terms of response activities, like we had during the COVID-19 pandemic period. What are the differences comparatively? What happens in usual care compared to what happened during COVID-19 pandemic period, where we have almost total lockdown and very unusual situation in terms of vehicular movement and all that. So we're looking at what information we can get from these two scenario in terms of responses that have been carried out in the past. So some other things that we have done, and that we are writing manuscripts on that at the moment, is that we have provided capacity building training for about the entire personnel of Lagos State Ambulance Service. That is the about 234 of them, on basic life support, on first aid and other similar training modules, to build their capacity in being able to provide quality care at crash sites when they attend to crash victims. So basically, that's just an overview of the work we're working around, but I'm looking at providing a more detailed information on ongoing work that we are currently working on.
Yeah.
Thank
It
you.
sounds like you have a tremendous amount of projects going on, tremendous amount of work. That's phenomenal. Thank you for sharing. There's a lot I think we can learn from each other just to hearing you discuss these points. Thank you very much for trying to summarize what you're doing in this brief moment. Mary, do you want to check your internet again and see if you can talk a little bit about your projects? Mary? I don't know if she can hear me.
Thank you, Professor Sudha.
Yes, now I can
Can you hear me now?
Yes, go ahead.
Okay. Thank you so much. So my project for this master's, dwelling on tracking of surgical site infections, especially post-cesarean section and post-discharge, because we know our mothers here, we discharge them on the third day. We don't know what happens between the third day and the 6th week before they come for the first injection for the baby. So a lot happens that time. We have the perioperative mortalities, we have the neonatal mortalities which occur, and we also have other infections which can affect this mother and baby. So I'm thinking of using the healthcare providers, having a script for the healthcare providers to call these mothers on day 7th and day 30 at the community. The mothers they will not get, will link them through the community health strategy, where I'm planning to use the community health promoters, especially because we know we have a migratory community here in our area. And also we serve other counties. This is a referral hospital, especially the biggest referral hospital in this region. And also when we use the community health strategy, we want to get feedback on the deaths we don't get, especially post-cesarean section, because we know most mortalities, especially 70% of them which occur, are related to cesarean section, even in a facility setting. So that is what I'm working on. I will work on the script. I will work on the registers to capture this data so that by the end of the day, we can even know what kind of SSIs are we getting. Is it organ space? Is it deep or is it superficial? And why are they occurring in all our facilities? Because we might find that SSIs are occurring in one facility and that is giving a burden to the county. So we have to have a QI process on what we can do to curb those infections from occurring in that facility so that it doesn't affect our mothers and babies as well. So it will be like tracking the mother for SSIs, but also the mother-baby pair will be taken care of. Thank you.
That's fantastic. Thank you for sharing. And how are you planning on? It sounds like this is going to be an intervention you're planning, and the intervention is calling the mother, or is this purely observational? You're just observing this cohort of patients who've had cesarean sections.
So for the mothers who will be tracked and So for the mothers who will be tracked and they have issues and they will be referred through our referral mechanisms, we will work closely with the emergency center so that they can get the care they need in our referral sites.
But is your project going to be an interventional study or an observational study? Are you just doing additional observations now with your project compared to what the standard is, or are you planning on doing something different when you contact them? I don't know if Mary's internet is not working so well. So I don't think she can hear me. Okay. Well, thank you, Mary, for your presentation or your overview of your project, looking at surgical site infection in post-cesarean patients. We'll go around. Mo, would you like to talk a little bit about your project and where your projects are, especially with the recent events?
Yeah, sorry, I missed most of the talk.
We're just going around giving updates on projects.
Yeah, I tried to be to join as soon as I can, but I just couldn't. It's too bad because I have a few questions about the work that Mary seems to be doing. As you all probably know that we started a small neuro rehab clinic in Marrakesh, Morocco. And like I told Sudha when I spoke to her about this the first time, we were expecting your typical kind of neurological conditions in adult population, like traumatic brain injury, spinal cord injury, and stroke and stuff like that, to be the most prevalent diagnosis we will be dealing with. But in fact, like 6 to 8 months after we opened the clinic, we noticed that more than 65% of our patients were kids with cerebral palsy. and the root of that conditions can be traced back to maternal health and actually the conditions of delivery. A lot of hypoxia going on just before birth. Water sac broke down and nobody noticed, or delivery conditions is like, I wouldn't even say being used for cattle. It's even worse. And those babies, otherwise they're completely healthy, they end up with all kind of cerebral palsy diagnosis. So the question I have for Mary, if she's still with us, is did this program that she's running with C-sections, did it change the incidence of those conditions in your country? Have you seen any changes after that?
Yeah, I don't know how well Mary can hear us because
Oh,
the
okay.
internet connection seems a bit challenging. But
Okay.
I loved your question though, Mo, in terms of connecting the need for rehab services as a child all the way back to maternal health and the systems that are necessary for maternal health, including infection prevention, including hypoxia management. I think it just tells you how much health system-wide thinking there needs to be.
Yeah.
Mary, can you hear us to comment? I don't think Mary can hear us to comment.
Yeah. That's okay.
Yeah.
If you have your email, send it to me. I would love to connect with her.
Yeah.
Yeah.
That'd be great. I'll do that. But meanwhile, why don't you talk a little bit about where your project is standing?
Yeah, so the clinic has been shut down because of the earthquake that you guys all heard about in Morocco. Especially that it was in Marrakesh area. That's where the clinic is located. The impact of it, it's beyond what I could foresee, because you can tell, well, people were scared, or some of them are killed, some of them are injured, and after interventions of all kind of institutions and agencies, life will goes on once everybody has a place to live. But unfortunately, it doesn't work that way. I mean, these people didn't hear or experience earthquake for centuries, so it looks like the mental impact and psychological impact on the population is much worse than I was even imagining. Some people are refusing to go back to their home, although their home are completely unaffected by the earthquake, and they are just basically camping on the street. It's unbelievable. So the clinic has suffered some shutdown. Obviously, some of our staff also had to deal with the consequences. Two of them actually, they were homeless for a week because their home were condemned, and so work is going back to normal little by little. We were going to start the curriculum that Sudha is aware of, and Cody and a few others. This month we were actually traveling the 16th of October, and we have to cancel all of that and wait for things to clarify before we start again. So for those who don't know, this clinic is, like I said, it's a neuro rehab clinic that treating children and adults, and we have been training, thanks to the University of the Utah medical professionals and others from other states. We have been training those staff on neuro rehabilitation protocols and other clinical skills for the past 7 years or so. And then a couple of years ago, we came up with this idea of basically establishing a master's degree level neuro rehab curriculum, comprehensive neuro rehab curriculum in Morocco, so that they will have something, a program to use, so they can train their own therapists moving forward down the road. And so I'm hoping, obviously, people from the University of Utah who directly deal with the neuro rehab field will join us in the next 2 years or so. people like Sudha, who is a little bit indirectly connected to neurorehab, are also welcome to contribute. And we're hoping it will be like a beautiful 2 years curriculum program centered about neurorehab, but also include many other medical specialties that deal indirectly or directly with the neurorehab field. And this might interest you, Mary. It's our plan that once we established in Morocco, it's our plan to basically copy and paste in other countries, including yours, hopefully. And some other, I see Aitomi. Where is Aitomi from?
Nigeria.
Nigeria, okay. Yeah.
Yes.
So we have contacts in Nigeria, we have contacts in Ghana, we have contacts in Senegal, in Ivory Coast. We also have contacts, as you can imagine, in Northern Africa. So we're excited about this.
That's fantastic. Congrats on the momentum, even though it's been slowed by the earthquake. And the group doesn't know, but the American College of Surgeons Committee on Trauma, which is what verifies and accredits American trauma centers, has been asked by, I think, either the Society of Trauma in Morocco or the government. I'm not sure exactly who did the asking, but for that, the leaders from the Committee on Trauma at the ACS to actually go and visit Morocco and help to think about trauma systems there. So they were supposed to be going, I think, in the next few weeks. I don't know if they still are. No, I don't know if you've had a chance to talk to my division chief about it.
Yeah, we communicated, and unfortunately, again, earthquake, we were going to meet, and then the week before we were supposed to meet, earthquake happened, so we had to put everything on hold. But yeah, I noticed that the Moroccans for the past 10 years or so, they were very interested in the level 1 trauma model that we have here in the US. And they were preparing to establish one in one of the biggest cities, either Rabat or Casablanca. So I think this is another step closer to their goal, and I hope the University of Utah will be in the mix of it.
Oh, that's fantastic. And anybody else have any comments or questions? On a slightly different note, Cody, would you like to talk a little bit about the GECKO study and the and our involvement in that?
Yeah, sure. Sorry, one sec, I'll get my camera on. So the
And
GECKO
go ahead and
study.
just introduce yourself and
Oh
say.
yeah. Hi everyone. I'm Cody. I'm a second year medical student here at the U. Interested in global surgery. So thanks to Dr. Jairam, I'm involved in some stuff, and also working with Dr. Nunez here, specifically on the GECKO project, which is a project looking at kind of the global comparison of cholecystectomy outcomes and just tracking a bunch of different kind of like metrics to see how things differ from country to country or worldwide or within our own country as well. And so we here at the U at least are now in our second cohort of patients that we're reviewing. We just had our first one and we're almost done with that. We got a little delayed. I had like a final and stuff like that, so we're a little behind, but we're on our second cohort now, going through patients, doing all the data collection and the chart review for that. And we're gonna have a few more patients. It's like 10 to 15 patients at a time that we go through and look at what their surgery was like, and then we follow them 30 days out and look at any complications they had, and then track a ton of different metrics about that. And then we'll look at a year out to next year. And then we'll compare that to some other centers. It's like a huge multi-center study with thousands of centers all over the globe. So it's going to be pretty cool in the long run. But so yeah, for our progress, I guess right now we're on our second cohort. but I'm sure Dr. Jayaraman, you can explain a little bit more eloquently about the project if people have questions too.
Well, it's a chance for you to think through and talk about what the project's all about. But yeah, and I just put the link in the chat. It's run by the National Institute of Health Research Global Surgery Unit in the UK. But it is a truly multi-institutional observational study. Their previous studies, you've been familiar with COVID surge, or completely blanking on the other ones they've done. But they're all literally across 100 countries and several hundred institutions, enrolling tens of thousands of patients to look at it's largely observational, looking at quality of care. In this case, looking at for gallbladder surgery, do institutions follow established guidelines in different phases of care. In this current study, there are 9 different enrollment periods. Enrollment periods last about a week at a time, and so you basically collect information on all of the gallbladder surgery patients for a week across all 400 institutions around the world. And so you can imagine, even if it's 5 patients per institution times 300 or 400 institutions, you end up with a lot of volume. And then you try to do that, 9 times, 10 times, you end up with the kind of volume that then you can use to ask important questions that can help standardize care better across institutions. So I think projects like this, which are not enormously expensive, but are asking useful questions, can really transform how we make decisions and how we can standardize care, whether in Nigeria or Cambodia or US, it doesn't matter. We're all contributing to it. We're all learning from it. So that's really a fantastic way of thinking about doing projects together. So, so that's that project. Anybody else have any other projects you want to talk about? Tan and Anna, do you want to talk about the course that you guys were talking? Thank you, Cody, for talking about that. Appreciate it.
Sure, I'll go for it. Hi, hi, Dr. J. I hope you're well. My name is Tan. I'm one of the global surgery scholars at the center. Anna and I are working on an introductory to academic global surgery course right now. As of now, I think we're waiting to hear back from the Tom Hall grant to see if we got that and see how assess our funding situation prior to moving forward. In the meantime, I'm working on continuing to build this outline of this course and ultimately incorporate more aspects of the Delphi study that you published, you participated in, Dr. J, into more of the curriculum, also analyzing our current academic global surgery course right now that a past former student created, and see if we can integrate aspects of that into it, as well as exploring new kind of materials to integrate, which also includes different activities where we can engage our students a little bit more with the course, so it can be much more interactive and much more beneficial for them. And that's it. Yeah.
Great. Thank you, Tan. Yeah, so this is, as many of you know, this whole field of global surgery is, the concept in some ways is relatively new over the last decade or so. And so the question is, what is the actual content? What do we mean by global surgery? What are we supposed to know about or learn about or teach about? And so we finished this big project trying to determine that consensus around that content with a number of different people from around the world, about 60 different people. And that was this Delphi study. Delphi is basically an iterative survey process to develop consensus. on a particular topic. And so what we're doing now is based on that. That's the first sort of formal attempt at trying to determine what the content should be for global surgery. So if somebody says, I'm interested in global surgery, what is it that they are interested in? And what is it that if you say, I have a certificate in global surgery or a master's in global surgery, what is it that you expect that they would know? And just like if you say you have a PhD in mathematics or a PhD in astrophysics, like there's some certain specific content areas. And so that's the first step. So the next step, of course, once you establish that, is then to create the curriculum, the courses that actually reflect that. And you can do that at any level. You can create a course of 20 hours in length. You can create a PhD program of 5 years in length, depending on the depth of covering that content. And so we're trying to figure out if we can create a short course online, freely available, that just scratches the surface and is an introduction based on these content areas. And we may tap into many of you to contribute content to it if you're interested as speakers or writers as we progress, so that we can develop a truly collaborative intro course that all of our students or colleagues, anybody who's interested. So that's our goal, and our goal is to actually also have it be a credit, course of credit at the University of Utah, so that the university can offer it as a formal course, and not just an online course that doesn't have any specific certificate associated with it. Any other comments along those lines? Questions, thoughts, concerns? Okay. Kind of almost out of time here for today. Anybody else have anything else they want to share or discuss? Questions, thoughts, comments, suggestions? I didn't ask some of you to talk because I wasn't sure if you had specific projects you wanted to talk about, like Kate or Eric or others. But if you do, just jump right in. Okay. If not, I think we'll wrap up for the day. Kate, did you want to say anything?
Hi,
Sorry,
nothing much to update you on, just kind of coordinating with Dr. Harris. My name is Kate. I'm a nurse practitioner at the U with kind of a background in ICU care, work in palliative, and have a love for global health. But just coordinating with Dr. Kate Harris, who is going to be, it sounds like, traveling out to Rwanda sometime this month. And just kind of in this brainstorming phase of maybe some projects to start in terms of kind of a needs assessment with pain management, addressing kind of cultural barriers to kind of pain management and in post-op patients, and kind of seeing where we could focus our efforts. So small steps, but very excited.
Fantastic. Great. Well, wonderful. Thank you for mentioning that. I realized that we did a pain project with the EMS crew. Actually, a lot of it had to do with maternal health, not so much like cancer related, but more labor and delivery related. I might send you that link, see if that's useful to you. Great. Well, thank you for that. Any other thoughts or comments from anybody else before we say goodbye? Okay, great. And then one last announcement. Next Monday is our next lecturer, who's a surgeon in I want to say rural India. He is been developing a variety of sort of process and program innovations that he is known for over the course of decades. And he was recommended to me as a speaker by the editors of PLOS Global Public Health. It was somebody class I taught in a few years ago. And so it's really about surgical innovation. So if anybody's available, please attend that. It's going to be entirely online. It's going to be 11 o'clock at night for him in India. And he's still going to be giving us a talk at that hour, which I'm very grateful for. And then for those who are in Utah, we'll have lunch. So we'll meet in the Helix building. So with that, thank you so much for spending this hour and talking about all this great work and energizing each other about ways we can make a difference in the world. So thank you, and have a wonderful rest of the day.
Thank you.